Welcome, everyone. I'm just going to wait a few minutes before we get this started. Let's get started. Welcome to today's webinar, Managing Lingering Side Effects After Breast Cancer, What's Normal and When to Get Help. I'm Kathleen Fitzer, and I'm Share's Metastatic Breast Cancer Program Director and host of our NBC Life podcast. Before the presentation begins, I'd like to tell you a little bit about Share. We're a national nonprofit that supports, educates, and empowers anyone diagnosed with breast or gynecological cancers and provides outreach to the general public about signs and symptoms because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, podcasts, and our helplines, please visit our website at sharecancersupport.org. Now, we have a few housekeeping reminders for you. All participants will be muted during the presentation, and a reminder that the chat is enabled, so feel free to write comments and engage with each other. Make sure to select everyone when using the chat. Once Emily finishes the presentation, we'll begin the Q&A discussion. Please submit any questions through the Q&A section at the bottom of your screen. We've had some questions that were submitted with registration, so thank you to everyone who submitted your questions. Remember that the speaker cannot give specific medical advice, so please keep your questions general in nature. We also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of the screen and selecting the subtitle option. And lastly, this webinar is being recorded. We'll share the recording in a few weeks with all registrants, and it will also be added to our website. Now, I'd like to hand it over to Emily to introduce herself. The screen is yours.
Thank you. So this is such a nice slide. This is, I was going to do my own slide, but I love this is lovely. I feel like, maybe I'll just take a look at what it says about me. No, I'm really happy to be here. I'm a nurse navigator by training. I've been a patient navigator and an oncology nurse for about 20 years, most of that focused on breast and GYN oncology. I am the daughter of a breast cancer patient, as well as have had many family members and friends. So I have gone through this as a caregiver. I like the term co-survivor. That's kind of what I think of it as often. It's like, I'm along for the journey. And I'm really excited to really dive into the topic today, because I think that, we really don't give patients enough space to talk about managing side effects. As I was talking earlier, we were chatting about just this topic, and I think the side effect management is really about quality of life and about addressing patient needs. So I'm going to dive into the presentation. I look forward to a little dialogue afterwards. So please, as you're thinking of them, put your questions in the chat, and we can address them when we get done with the presentation. So I'm going to go ahead and pull up my slides here. You guys can see everything there? Looks like it.
Yes, perfect.
Okay, perfect. Thank you. So, so we'll be talking about the lingering side effects. So when we talk about breast cancer, whoops, let's see if I can. Okay, there we go. When we talk about breast cancer, we're really talking about, like I said, quality of life. So again, this is me. You just met me on the other slide, but this is a little more about me. This is my family that get to go to Miami Breast Conference with me every year. So I was part of the patient advocacy program last year. So anyway, I just wanted to put a little personal piece, and then these are some of my colleagues celebrating at an awards gala a few months ago. So when we talk about survivorship, I think the first thing is to really think about how prevalent this is, that this feels like when you're the one in the clinic who's dealing with the side effects, or you're the one who's up at night with hot flashes, feeling so miserable. I think it can feel like very isolating and that you are the only one. But the fact is that we now have about 18.6 million people in the United States living with cancer. Now, that's not all breast cancer, and they all certainly have different types of side effects, but just putting in perspective that 1 out of 18 Americans alive today is a cancer survivor. So that statistic is really significant. And that number is only going to increase because we are doing a better job of keeping people who have cancer treated and keeping them alive for longer. And while that's wonderful and absolutely something we should celebrate, it doesn't come without side effects, right? It doesn't come without quality of life concerns. And so I think as we move towards that number and increase that number, the healthcare professionals like myself need to do a better job of addressing survivorship needs. And so today, when we talk about managing side effects, long-term side effects, we really are talking about educating patients about what is normal, what is not normal, and then what to do about it. And at the end of the day, and I'll say this over and over again in this presentation, I really feel like the biggest message and the most important thing for you to hear is that this is an ongoing conversation and that you are absolutely empowered to have the conversation with your team. So if you're having side effects, if you're having concerns, new ones, lingering side effects, suddenly you're having pain, or you notice that you're more forgetful than you were, or you're dropping things, or you're concerned about numbness and tingling in your feet. Maybe it's harder to walk long distances. These are things that are important to report to the team. Now, they may talk to you and say, well, given your treatment and the fact that you're on this certain medication, we would expect that side effect. And so that can be reassuring, but it may also be a sign of something else. So again, before I even get started, I just want to really empower you to be advocates for yourselves and communicate with your team those issues that come up, those quality of life issues. Because as we move forward with more and more survivors, we're going to have to address more and more of those concerns. So I don't need to tell you all this, but breast cancer treatment can be is different for everybody, first and foremost. So when I talk about someone who had HER2 positive breast cancer, it's very different than somebody who had early stage DCIS that maybe just had surgery, not just had surgery, but had surgery as their primary treatment, and then maybe radiation, or maybe not radiation. And maybe that person is on tamoxifen, but hasn't ever taken systemic chemotherapy. Someone with HER2 positive disease might be on Herceptin for a year. So that treatment would look different and those side effects might look different, from patient to patient. So I put this up there just to sort of remind that some people's treatment can be over and done with in as short as 6 weeks. Someone who doesn't need endocrine therapy is somebody who just has a surgical treatment and then maybe radiation or maybe no radiation. So, and some people go on to have treatment for years and years. If someone's being treated for metastatic breast cancer, locally advanced breast cancer, they might be on tamoxifen, say, for 5 years, or an aromatase inhibitor, something like letrozole, or one of the other oral pills for 5 or more years. So, some of this treatment, it looks different, right? The early part of treatment is when you're busiest, you're going to all the appointments, you might be going to the clinic on a regular basis. And then as you get further away from that diagnosis, you start to follow up less frequently, unless you're continuing to get treatment. So when we talk about treatment effects, many of the ones that we talk about first up are short term. So we have you sign that long consent form that talks about what you might experience with chemotherapy, for example, hair loss. That typically is temporary, right? As soon as you're off that medicine, your hair will grow back. Now, that's not true for everybody, and a lot of times people will have their hair grow in differently than it was before. If it was bone straight, now it's going to be kinky curly, or vice versa. That happens, pretty commonly, and that's something that patients may not be prepared for. Things like nausea and mouth sores, those tend to be more acute. We see them in the clinic when we're giving treatment. And once the treatment is done, we don't see those anymore. People will recover from those. But again, sometimes taste changes, some of that cognitive, brain fog, or chemo brain, as we like to call it, might remain. And that can be normal. So that's something to discuss with your provider if that's a concern. But most people will experience some long-term side effects. And I will say that among providers, I think there's this balance where, I've noticed that some medical oncologists, radiation oncologists, surgeons, some treating physicians will kind of minimize the conversation about long-term side effects in order to encourage the patient to continue on therapy, right? And so there's a balance. And I laugh a little bit when I say that because it's not meant to, you know, trick you into something, right? But I think there is sort of a give and take. And again, getting back to what I said before about the conversation, I think it really empowers us to have that discussion, you know, and to feel empowered to have a two-way conversation. So you're more than welcome, in fact, invited to bring these concerns up with your team at any given point and to kind of monitor things over time. You know, let them know how it's going. You can say, you know, I've just noticed I'm just more forgetful. I'm not able to remember names. I'm not able to have that recall that I had before. Well, some of that is aging, normal, and some of that is stress, and some of it can also be an effect of the treatment. So it can be a mixture of things, but it could also be something over time. If it seems to be getting more and more concerning, you know, we want to hear about that. We want you to bring it up. So those long-term side effects can be, like I said, they can happen, you know, just a few months after treatment starts. Like for example, something like heart impact on like heart muscle, like somebody who's on a medicine that might be known to cause cardiomyopathy could start having shortness of breath or having a symptom that's like really while they're still getting the treatment, they might have a response. And that would be something that, of course, we would want to know about right away. But those side effects can also be a few years after treatment. Someone who's had, for example, radiation or HER2 therapy might be increased risk for heart disease. And so if they suddenly start to feel winded or short of breath when they're going upstairs, we want to know that. We want to hear about that as a clinic side effect. We want to hear, you know, what's going on with that patient. So these are some of the common physical concerns that we see when we talk about late effects. So these are effects like lymphedema. So lymphedema is swelling in the extremities. So oftentimes we see it in the arms, the upper extremity with breast cancer patients. And this is, you know, this happens because during surgery or radiation, the lymphatics can be disrupted. And so those lymphatics whose job it is to take fluid away when there's inflammation just kind of get congested. And so you start to see swelling. And I've seen patients, you know, years out from surgery. Maybe they didn't even have a lymph node dissection. Maybe they just had a sentinel node procedure. Just a couple of lymph nodes, you know, were impacted during their surgery. And they get a bee sting, or they're in the garden and they get some poison ivy or some sort of inflammation happens to their extremity and their hand swells up. And it swells up a lot more than you would expect from a typical insect bite or, you know, a minor burn. And that would be an indication of lymphedema. But it can also be just tightness. You notice one day that maybe your bracelet or your watch or your ring is a little tighter around your wrist. So lymphedema, that's, you know, one of those late effects. Heart health, I talked about this before. This can be related to treatment. So we can see certain drugs, particularly the HER2 family. Anybody that was on anthracycline. So a lot of times patients with triple negative breast cancer are on anthracyclines, doxorubicin. Those can cause heart issues long term. So for patients that get those drugs, typically you will have gotten a scan ahead of time. They'll be checking what's called your ejection fraction ahead of time. And that's to kind of make sure that we have a baseline before you start treatment to know how well your heart muscle is pumping. And if there's a change, then we know over time what that might be. And so that is, you know, where heart health comes into play. Bone health. So bone health is a big one. And this is one, honestly, I think we don't do a good enough job talking about bone health in our healthy population and our non-cancer survivor population. But women, particularly as we age, as our estrogen reserves drop, are at risk for osteopenia, which is bone thinning. Women who are on aromatase inhibitors, tamoxifen, medications that block estrogen are going to have an accelerated path to osteopenia. So they're going to be at higher risk for thinner bones. And so the importance of things like weight-bearing exercise, making sure you get enough calcium, healthy diet rich in vitamin D and calcium is really, really important. And also important to have those studies. So things like bone density tests before treatment. Pain is another one that I think we just don't do a good job as a society handling patients' pain. We could have a whole seminar about that, about managing cancer pain. But, you know, I think this is one that often goes addressed and we don't often make space to discuss pain concerns with patients. And I just want to again encourage you, if you're having pain and discomfort, to let your team know that, they may not be concerned or may not seem concerned at first, and that's fine. Just to bring it up and discuss the concerns that you have. I think what we would be more concerned about is pain that's new. So we may ask questions about, did this come from an injury? Is this repetitive motion? Is this from something that's new that's happening in your life that is causing the pain? Or is this pain in a place that you've never had pain before? And it can be a concern because we sometimes see pain as the first sign of a recurrence. So you might have pain that could be, symptomatic of a metastasis, a bone metastasis or something. So the concern there is to make sure that we're not missing signs and symptoms that are concerning. But typically that can also be addressed quickly because we can do imaging, hopefully rule that out and manage the pain, manage the concern. So these are late effects that can be from treatment. You can have pain. Some patients have neuropathy, which is the sensitivity, kind of the burning or numbness from the chemotherapy that can continue. Sometimes that shows up as like pins and needles kind of feeling in the extremities. It can be in the toes and the fingers and the joints. Joint pain is another one that we see a lot with particularly people that are on those estrogen blockers, tamoxifen, aromatase inhibitors. What we tend to see is that the joint pain is worse initially, and then eventually it does get better. And sometimes that's because people know how to manage it better. Sometimes it's just the body's kind of initial response to a new medication can just sort of be like an inflammatory response where you just sort of, your body's almost in shock, like what's happening. And then over time it sort of adjusts and things settle down. So oftentimes with joint pain, the suggestion is to monitor it for a while and just see if it's something that is tolerable. Sometimes changing the time that you take the medicine. If the joint pain's really bad in the morning and you're taking your pill in the morning, it might be easier to take the pill at night. Again, we can adjust things. But the most important thing is that you communicate about those effects so that you can continue on your therapy, because ultimately we want you to be successful in treating your cancer. Fatigue is another one that I think a lot of people just think, oh, well, I'm not going to talk about this one because I'm tired and, nobody wants to hear about how tired I am. No, we do. We want to hear about that. We want to know what your fatigue is, how it's impacting you. If it's impacting your ability to work, if it's impacting your ability to drive safely, if it's, impacting your ability to enjoy your quality of life, to be around your family. We want to know that, is it about a sleep disturbance? Sometimes that can also be a sign from, estrogen deprivation. Someone's having a hard time falling asleep or staying asleep. So is it fatigue from that? Is it fatigue from the stress of the diagnosis itself? Or is it something, else that we need to deal with? Weight gain and weight loss, again, this is one that comes up all the time. And, for some people, the treatments can cause disturbances in the metabolic function. So sometimes you don't change the way you eat, you're still exercising, or maybe, you start exercising and you're not losing weight. And that can be really frustrating. We can see metabolic changes, impacting because of the hormones, the connections between the hormones with these drugs. So again, these are things that you can sort of expect, but also we want to hear about them and we want to discuss them. Hopefully these are conversations that are coming up at survivorship clinics, follow-up visits, that your team is talking to you about. If you're getting care at a center that has a survivorship clinic, it might be a nurse practitioner or a PA, perhaps somebody else from the team. You might even have a physical therapist as part of the team that's kind of doing some of this assessment to help you kind of, understand your options as far as managing weight gain, weight loss, and those kinds of changes. We talked a little bit already about brain fog, cognitive change, memory problems. Again, these are somewhat expected with some of the medications. We see this consistently, particularly with chemotherapy. Again, I think the jury's out in terms of what the causes. It's not just one from the medicine. It can also be from a combination of stress. We know oxidative stress is just your cells being overwhelmed, right? And that's certainly the case when you've undergoing systemic treatment. So again, these are side effects that can be normal and can be managed and dealt with, but we want you to report them so that we can get you to the person that can help with that. Menopausal symptoms. So this is the biggest one for breast cancer. I think that we tend to see across the board. And certainly this can look very different for a woman depending on age. So for women who are young with breast cancer, our 20, 30, 40-year-old population, this side effect can often be the one that really impacts their quality of life the most because they get hit with this estrogen deprivation really out of the blue. Just suddenly, it's like a ton of bricks. Just suddenly, when you start taking those medicines, your ovarian function just basically kind of shuts down, whether it's chemotherapy or if you're on something like tamoxifen. So hot flashes, sexual function, of course, this impacts intimacy, relationships. It can also cause UTIs. And so sometimes there's pain even without sexual intercourse. There can just be vaginal dryness and vaginal pain, pain with urination. And so again, these are things that can be managed. There are definitely things that we can do to address these side effects. And we certainly want to do that because the last thing we want is for somebody to say, well, I just don't want to have these side effects, so I'm going to go off my treatment. That's not necessary. You know, at some point, if certainly if that's the decision that the patient makes, that can be understood, but we don't want the person to get there by themselves. So I can't tell you how many patients have admitted to me over the years, you know, oh, I stopped taking my aromatase inhibitor because I just didn't feel good on it. I just felt terrible. I had this joint pain. I had this, you know, sexual side effects. My libido was shot. I didn't have any interest in, you know, intimacy with my partner. Like whatever the conversation is, we don't want that to get to that point. We want you to get assistance before you get to a point where it impacts your overall quality of life. And then for the younger women who are still family, kind of in that kind of family building phase, loss of fertility can be a big late term effect. You know, we see this primarily with our younger patients who, you know, get breast cancer in their 20s and 30s prior to completing their family. Maybe they've had a child, maybe they want to have more children, and the treatment can impact their fertility. So these are late effects that need to be addressed again early on, hopefully before treatment even starts, to have a conversation about fertility preservation. And I know there are others. This topic, obviously, this conversation could go on for hours and hours. We could do a whole weekend presentation about this list that I've just gone over in the last few minutes. So again, just the message I want to give you and empower you is that the symptom management, managing all of these that we've discussed, is our job as your oncology team. So it is our job to assist you in having a quality of life. As patients have told me over the years, what's the point of working so hard to be cancer free or to be living with cancer, or to be, you know, no evidence of disease or whatever we may kind of, you know, be planning for you for your treatment, if you don't have good quality of life, if you're sitting at home because you're in pain, or you feel like you're unattractive because you can't, you know, you have hot flashes and you can't have that connection with the partner, intimacy, or you just have brain fog, or you feel like you can't get up and safely walk because you have neuropathy. These are things that make someone's life really diminish the quality of their life and really make them feel terrible about things. So we want to address all of those things can be addressed. And I want to bring up the topic of palliative care, because I think when we talk about symptom management and we talk about long-term cancer treatment, we need to talk about palliative care. A lot of people think that it's hospice. It's not. Palliative care is simply symptom management. It's simply meeting the patient wherever they are and addressing their quality of life concerns. So it can be scary because I think a lot of people do think palliative, think, oh, well, that's just comfort care. And that's just, you know, trying to help me feel better. And so that's like hospice. Well, no, it's not. Palliative care certainly can be a part of hospice, but it's not the same thing. So I really want to demystify that concept and have people feel empowered. You can start getting palliative care. I mean, people that don't even have cancer can get palliative care, but palliative care is symptom management. So you can literally start, if you are going to a rehab to help with neuropathy, from your second cycle of chemotherapy, that's a form of palliative care because you're managing a symptom. You're managing a symptom of your treatment. And so there are palliative care clinics, there are palliative care specialists. A lot of cancer centers, either employed or by referral, have providers that you can see to manage symptoms, and they'll work alongside the oncologist. Sometimes in different programs and it looks different. Some of the academic centers have a clinic, some more community hospitals. I'm in a community center, so our palliative care is inpatient, which is wonderful if you happen to be in the hospital, but most of our patients aren't. But we can refer them to someone in the community. So there are clinics that patients can go to and have conversations about managing their pain, their fatigue, their neuropathy, their lymphedema, all of these things, their sleep disturbances, whichever they may be. And with the management of symptoms, there is certainly the traditional medical approach, and this would be the importance of referring to a specialist. So we talk about a heart problem, we're going to send you to cardiology. Your oncologist, while they are certainly know all there is to know about the treatment of cancer, are not specialists in managing heart disease. So they're going to work with their partner, their colleague, who is a cardiologist, who is a specialist in heart disease, and get you the support that you need to thrive. So same thing, we're going to call in the physical therapist. We have pelvic floor therapists that can help with the sexual side effects. We have gynecologists that can help with sexual side effects and helping with hot flashes and managing the menopausal symptoms, and also the sexual and intimacy pieces. So it may be that somebody, needs some, a prescription for topical estrogen to help with some of the vaginal dryness. That can be contraindicated for some patients with breast cancer, but that's where a team approach really, really is important for those physicians to come together and say, okay, how are we going to address this patient's quality of life? How are we going to address this person's need? Same with endocrinology and other specialists. There's a long list of specialists that you might be referred to. I've mentioned survivorship clinic. I think this is the ideal, and many programs have a survivorship clinic. If they don't have a dedicated survivorship clinic, they might have a provider who provides support, kind of helps to coordinate these referrals. And so at each cancer institute where you may be treated, you may see this look a little bit different. In certainly rural settings, people that live, in further out from a large city might have to go to referral based, where they might have to drive a ways to see a specialist. And so a lot of times this is coordinated through a survivorship program or survivorship clinic. I mentioned rehabilitation and physical therapy. A lot of people think about this for lymphedema. Some patients see these specialists prior to surgery to kind of get like a baseline. But oftentimes people don't realize that physical therapy is also available throughout the continuum. So again, they can help with pain, they can help with limited mobility. If someone's having difficulty with neuropathy, there's physical therapy interventions that can be done with that. And certainly if someone is starting to exhibit any signs or risks for lymphedema, that would be a great resource for a person. Prescription medicines can help. And then mental health and cognitive behavioral therapy can also really help. This is difficult when you're managing something long-term. It can be overwhelming, and it can require additional support, mental health support, in addition to the physical or prescription, perhaps, medicine. And then the integrative approach is something that, I think we're starting to really understand more now and really trying to embrace. And this is something that, again, if you live in a large city, this might be something that's more accessible to you. But things like, we're seeing more and more things like meditation classes, mindfulness classes in the cancer center, yoga, recognizing that there is a lot of benefit to just moving your body, even in a very gentle, very slow, focused way. It's just really, really good for your overall well-being to move, and it doesn't have to be in any hard, intense aerobic way. It can be just, again, the evidence is really supportive of exercise and mindfulness, in particular, just the mental health and the physical effects. And then I've listed some other things here. Exercise and nutrition, of course, is key. But things like aromatherapy, acupuncture, there's good data that acupuncture can really help with some of these side effects, things like nausea, pain, neuropathy, are all things. Reiki is a healing touch, is a way that a practice that you would see a provider who has Reiki training to kind of work with healing, and it can be hands-on or it can be remote. So it doesn't even have to have your hands on, to work with energy and healing from a more of a body-centered focus. Hydrotherapy, water therapy. So anytime getting in the water, I don't know about you, but I feel like a bath, a bath can solve a lot of problems. Sometimes just getting in the water, swimming. A lot of patients with joint pain, concerns with limited mobility do well, at least starting out in the water. So if you can take a water aerobics class, or even just stretching in the water, swimming, even just sitting in water, can help with joints and those side effects. Okay, so I had mentioned palliative care before, and I wanted to talk a little bit more about it in particular here. So palliative care, again, is something that can start on day one of diagnosis. It's really about alleviating pain and discomfort that's associated with illness. That is it. And so if you walk away from this talk with any nugget, it is that um, developing that, getting comfortable with the conversation around symptom management and palliative care in particular is important. And it can happen at any point. You can literally start on day one of your diagnosis, and start managing those side effects. And you can also stop at any point. So at any point that it's no longer necessary, you're not obligated to continue on. There's not a code for it that would indicate that you would be, nearing end of life. It doesn't have any connotations like that. So many people think that it does. They're like, oh, my insurance isn't going to pay for it, or oh, it's not gonna, they're gonna, think that I can't work anymore. And that is not the case. So it's really about coordinating support and referrals for symptom management. Again, survivorship programs can do this. If you're not in a place that has a survivorship program, your oncologist and even your primary care provider can coordinate referrals to a pain specialist or to a sleep specialist, to somebody that can help address the side effects that you're having. I'm a big believer in communicating in whatever way you're comfortable with. So a lot of us don't necessarily want to go into an appointment, for every concern that we have. We don't have time to follow up. And the clinic frankly doesn't want you to come in and spend time that maybe you don't need to be there. So start with the patient portal, start with a communication email. If your provider has like a way to do messaging, you can just send a message and say, hey, this may be something that you're not concerned about, but I need to report to you that I've been having this side effect. So let's say, for the last 3 nights, I have not been able to fall asleep, and I'm really fatigued. I don't know if it's related to my treatment. I'm really concerned about it. It's affecting my quality of life. That is a perfectly appropriate email to send to your provider, and you can wait for a response. And they may have you come in to talk about it more. They may call you. They may have you come in to see one of the other providers, perhaps the nurse practitioner or the PA or somebody who can help to address things. If you have an oncology navigator, I'm a big fan. I was in that role for many years. And I think that it's a huge resource if you have that available to you, to have someone to call. They can help put you in touch with the resources, many of them that I've discussed today. And again, it's so specific to where you are. So the Oncology Navigator is really your local resource. I used to tell people it was like an old timey switchboard operator, because you could call me and say, I need to talk to somebody who specializes in, you know, sexual health, for example. And so I would start to talk to you a little bit about, well, what do you need? Are you talking about a therapist? Are you talking about a pelvic floor therapist? Are you talking about rehabilitation, or, more of like a mental health conversation? So, we could sort of get to the key of what was going on and then make those referrals appropriately. And then again, social work is also similarly will work alongside often a navigator, kind of helping with some of those referrals to other resources. So maybe social resources. Maybe you say, I'd love to have these resources, but I don't have insurance. What's available to me? Well, in your community, perhaps there are social services and programs in place to help address some of these side effects that you wouldn't necessarily have to pay for. Some places offer support groups and things for free that you could attend, or have appointments with provider who's volunteering their services or is being compensated by the cancer center so that they're available to patients who need them. So don't ever let a barrier like cost get in the way of at least asking for what's available, because oftentimes your social worker and your navigator are going to be able to help you identify those resources. So where would I go if I have pain? Again, we sort of talked through these before, but this is just a quick list, and I'm just going to go down the list quickly just to kind of give an idea that, like, for every patient, it could look different, and every program it may look different. But generally, when you're having pain, you want to think about palliative care. There may be a pain clinic or a specialist. Sometimes it's a clinic that you can attend, you go to, and they sort of look at your whole body and sort of look at all the different aspects of pain. Are you having pain in a particular place? Is it treatment related, or is this something that's been chronic for you? A lot of times people with chronic pain, chronic injuries, it may be worse once they start treatment, or maybe their treatment impacts their mobility, and then that makes their pain worse because what was working for them before was, getting into like doing walks or, exercising regularly can interrupt some of those quality of life pieces. Lymphedema, neuropathy, sexual health, these are all great reasons to see a rehabilitation specialist. So this would be a rehab or physical therapist. A lot of times it's a department, so you might be referred to rehab for an assessment, and then they will determine, oh, you would be best helped by an occupational therapist, or maybe it's a speech language pathologist. Maybe it's something that's happening with swallowing. Maybe there's an impact that's happening from treatment that's causing you to have hearing loss. Maybe they're going to send you to an audiologist. It's all of these kinds of symptoms depend on kind of what the intervention may be. For heart health, we talked about cardiology. This is really important because an assessment is really key to determine whether what you're experiencing is treatment related. Is it acute? Is it something that is going to impact your treatment? If you're still getting treatment, do you need to stop? If you're done with treatment, is it something that you can safely manage while you're continuing to be sort of followed? So all of that is really important and very specific to the person and to the diagnosis. Bone health often will be a primary care or OBGYN referral because they would want to make sure that you've been assessed for bone density. And then if you need a supplement, if you need something for for bone health, for that calcium or something like that that you need to take as a medication, they can prescribe that and make sure that that's managed appropriately. For concerns around weight loss, weight gain, metabolic changes, again, primary care can certainly be the sort of start. Certainly oncology, I should say that all of these are sort of within the purview of oncology as well. But we certainly would want you to talk to your oncologist first, and then they might connect with your primary care and then refer to endocrinology or to a gynecologist or to a specialist who can help, depending on kind of what the concern is. And then fatigue, mental health, cognitive changes, memory problems, that would be more primary care and mental health. And then your menopausal symptoms are going to be primarily, can be depending again on the circumstance. If the patient's still on therapy, if they're still getting tamoxifen, still getting chemotherapy, it may be a conversation between the gynecologist and the oncologist. How are we going to manage this patient's sexual health? What can we do to address this? And we can bring endocrinology into that as well. So again, depending on the side effects, hot flashes, sexual function. If we're talking about fertility, it may be, reproductive health referrals. That would be different, than someone who's just having sexual side effects, right? So again, there's a whole myriad of people that can be referred to. And you don't need to remember this specifically, but just to know that there is help, that there is somebody that cares deeply for you and the side effects that you're having, and that these don't have to be suffered in silence, that you do have resources and a way to get to those resources. So I cannot talk about long-term survivorship without talking about the emotions, the emotional part of it, and the absolute myriad of psychology that happens when someone's diagnosed with cancer, from the beginning to their whole continuum of care throughout their treatment and after. So I don't have to tell you all. It's a mix of gratitude, anger, grief, loss, fear, and that it can change day to day. So I like to frame and give permission for patients to feel these feelings and to feel them at the same time, that it is more than normal and more than okay to get comfortable with what I call this paradox of survivorship, where you can be grateful and also pissed. You can be angry and also happy, right? You can be two things at one time, because you can know and hold on one hand that your life is precious because you've been reminded that cancer has come and you have had to deal with it, and that is really scary and really hard, but that you also have your life and your quality of life, and so you have one in each hand. And so again, that paradox, I think, just gives permission, if nothing else, to kind of just explore what those feelings and those complexities may be. And I love this quote. Kate Bowler is a cancer survivor, stage 4 cancer survivor, young, diagnosed in her 30s, and she has a beautiful podcast called Everything Happens. And I highly recommend it. But her quote here is so lovely: "Life is beautiful, life is hard." It's both. It's life is beautiful and life is hard. So again, if it's helpful to you to sort of think about this, sometimes we call it sweet and sour. It's like you hold it in one hand, right and left. This both and thinking. Grateful to be alive and angry. When I look in the mirror, I see scars where my breast used to be. I'm happy to have a supportive partner, and also sad that I don't enjoy intimacy like I used to. So, it can be sort of a way of adjusting our thinking. I'm not going to go into all of these. I think these are fairly well known, but they're here really to remind you just that there are things that you can do. So for bone loss, we have a list of things that we can kind of do to address bone loss. Hot flashes, we have physical things that can be done in addition to medical management, which is one of the things that we can certainly do. There's certain things that trigger hot flashes. So we tell people, not to eat hot, spicy food or drinks that are warm, caffeine, stress, smoking, things that are going to excite your nervous system. What you want to do is relax your nervous system. So things like mindfulness, yoga, stretching, having that sleep hygiene where you're sort of winding down before you try to fall asleep, things like that can really help with hot flashes. And night sweats too, just sort of planning ahead, for your environment. For vaginal dryness and pelvic floor tightness, there are multiple, and I feel like this topic is finally getting the awareness that it deserves from the public. Women are finally getting to talk about menopause and talk about menopausal symptoms in public. And so, if you are on social media, that there's all sorts of resources. Some of them probably not exactly safe or what we would recommend, but certainly to have the conversation. Again, I think if nothing else, I want to empower you to have this conversation, to not feel embarrassed to walk into your clinic and say, I'm having vaginal dryness and it's impacting my quality of life. If it's pain because of having pain with intercourse, or having pain when you're having even like inserting a tampon, or having any sort of penetration, things like water-based lubricants can be helpful. Again, pelvic floor therapy is available for patients. A lot of people like to use a moisturizer. So, some people use something like coconut oil. Other people like, the actual, there's over-the-counter and prescription, like vaginal moisturizing products that you can get. And people like to use those and try those. Libido and loss of desire, this can be immediate. So a lot of times it's like night and day. You start taking these meds and suddenly you just have zero sex drive. That is very expected. It is often not discussed. And so it's important, I think, to just recognize that this is a known side effect and that we have ways to address what may come from your treatment. And I cannot talk about long-term survivorship without talking about mental health. So, the anxiety, that fear of recurrence, that is, patients talk about, that is debilitating as physical effects can be sometimes. Just that fear and that concern about what's going to happen to me. What if I recur? What if my cancer comes back? How can I live in my life in a normal way in between scans if I'm just constantly afraid that I'm going to get bad news or get, the news that it's recurred? Or if someone's living with metastatic disease, going from scan to scan, going from treatment to treatment, how do you kind of keep your focus on your quality of life when when it can feel consuming and kind of overwhelming? How are those relationships impacted? So not just with your partner, certainly your family, someone you're dating, someone you're intimate with, married to, but also those relationships with your healthcare providers, with fellow survivors. When I go to a support group, sometimes patients will say to me, I feel so deeply for these people in this circle, but it's so hard to take on what they're experiencing alongside my own grief and my own pain. So sometimes maybe just being conscious of that and having somebody to help kind of manage some of those complex feelings can be helpful. For a lot of people who are working, colleagues that don't understand that, your quality of life impacts from your cancer treatment are impacting your performance at work, the fatigue. Maybe it's mental health. Maybe it's just that you have a different perspective. You're kind of trying to live for today. And, folks around you are so focused on things that may seem insignificant. And so it's managing those kinds of relationships that are impacted by your treatment. I think I skipped and didn't mean to, but depression. Depression is one of those things that, again, can be something that's present prior to treatment and prior to diagnosis, and then can be exacerbated. Some people, are diagnosed for the first time after their treatment because they finally get therapy. They finally go to a provider and they say, I felt this way for a long time, but now that I have cancer, I'm noticing that it's worse. I'm having a hard time um, getting over these feelings of defeat or these feelings of sadness. And sometimes they're diagnosed for the first time, but they've been having those symptoms maybe throughout their life or for a long time before their treatment. So I've seen many patients get a proper diagnosis of depression. And sometimes it can be acute. It can be something that's happening because of the treatment, because of the diagnosis, but it doesn't have to be. And so I encourage absolutely patients to follow up with a professional. The oncology social worker in your practice, wherever your provider is a great place to start. They can kind of talk to you about doing an assessment and make referrals. And then again, just recognizing that uncertainty is part of being someone who lives with cancer. So what does that look like? And it looks different for everybody getting support, getting help. These are some examples from groups that I've been a part of, who have used things like online support forums. I mean, certainly Share has a plethora of resources available in this community, which is one of the wonderful things about it. But opportunities for journaling, walking together, hiking, groups that can form around a common interest. Things like taking a walk. Like I said, a bathtub will cure at least 25% of my woes. Most of the time, I can just get in a bath and just relax in water. I'm going to feel better. Um, sometimes laughter. For some people, it's just a funny movie. It might be, a great book, just having a little bit of downtime. And I tell people, self-care doesn't have to be massages and fancy meals and a big trip. It can be something as simple as walk outside, give yourself the gift of a sunny afternoon, even if it's for 10 minutes, or to just call a friend that you haven't talked to in a while who always lifts your spirits. Like, it doesn't have to be expensive. It can just be something to say, hey, I just need a little pick me up and I wanted to hear your voice. And certainly, spending time with family and friends. So really get clear about what those things are that fill your cup. And those are the things that you want to have on the ready when you have a day that feels overwhelming. Um, So this fear of recurrence we talk about all the time. It's in its own way a long-term effect, right? And it does seem to ease with time. If you're finding yourself more and more anxious, it probably is a good idea to talk with someone who can sort of work through some of the concerns. Anxiety is a real thing. So that, rapid heartbeat, that inability to sleep, that nervousness prior to a procedure, prior to a scan in particular, where you're going to get some information about, whether your treatment has been working or whether the cancer has come back or things like that, can be really important to acknowledge. And I think to sort of have a plan. So I have patients a lot of the time will have kind of a scan up maybe a week before, and they'll have a plan. Like, I'm going to check in with a friend. I'm going to go see my therapist if I have one. I'm going to kind of notice the results. I'm going to come up with a plan for knowing what the results are going to be, how they're going to be communicated to me. I'm going to ask my provider, okay, I'm going at 4 o'clock on Thursday. Will I have results by Friday and get through the weekend? Or should I just plan to kind of get through the weekend and have that conversation with you in a week afterwards, or whatever that may be. Maybe you're going to get the report through the portal Is that going to scare you? Is that going to be a hard thing if you don't have a provider to talk to? Kind of plan for some of those things so that you can adjust your expectations. And then really think about, you know, do I need to? And I think this is a great way to call your mental health provider at your practice where you're getting your cancer care and just say, I'm just feeling overwhelmed by this fear of recurrence. Is there somebody I can talk to, and help them help you assess whether it's something that really needs professional guidance? Things that are in your control, and I'm going to not go over these because I want to leave time for questions, but scheduling follow-up appointments are a great way to find some control in this feeling of like not feeling like you have control of the situation. Things like choosing what you're eating, certainly smoking cessation if you're smoking, and drinking. The more you can limit, the more and more research. Obviously, smoking we know has a huge is a huge impact in cancer development, but alcohol more and more too. So limiting that where you can, focusing on your emotional mental health. Again, physical therapy, preventive. It's not just when there's a problem. It can also be something that's helpful ahead of time. So you can do exercise classes. You can work with a physical therapist just to help increase your joint mobility and not expect it to get worse over time or as you age. And then just sort of have a plan. And again, it doesn't have to be expensive, but a to-do list or things that you really want to accomplish, and start checking those things off your list. That's a way that we can kind of take care of ourselves and have some sense of control over what the quality of life is going to be going forward. Okay, so these are our questions, and I'm going to open it up for discussion. I think we have some in the chat. I see the chat's been active, so thank you for your conversation there. And then I'm just going to put my contact information here just so you'll have a way to reach me. I am more than happy for you to text me. I'm more than happy for you to send me an email to continue this conversation. If there's specific personal things that you want to share or get some guidance on, I'm happy to kind of put my resources to work for you if there's something I can help with. But I will stop talking. I can't believe that we're almost to the end, but I think Kate's got questions, and we can kind of just hopefully have a little discussion here at the end.
Thank you so much for the presentation. Let's start the Q&A. You can still submit questions in the Q&A section at the bottom of your screen. We'll try to get through all of submitted questions, but we may not be able to due to the time constraints. So we did have some submitted questions, and let's begin with one of the most common concerns that we've received about tamoxifen. There were several questions about the side effects of tamoxifen. Can you talk about managing those side effects and what the side effects are?
Sure, sorry, I'm going to take a sip here. Yeah, so the main ones that we see with tamoxifen, like I mentioned before, are with our younger patients, sexual side effects in the estrogen deprivation. So things like hot flashes, sometimes it may not be a night sweat kind of situation, but just the temperature regulation. So suddenly patient feels really cold, they feel really hot. It's sort of this like change from one to the other. Vaginal dryness, we see joint pain is one that we hear about a lot. So a lot of those again are, you know, my experience anecdotally is that as if a woman is younger and has, let's say, is further from natural menopause, those impacts are often more dramatic. Not that's not always true, but I think just and it makes sense. Like if your body is going from like kind of full throttle, estrogen production in your ovaries and your endocrine system is working in your 30s, and then suddenly you're taking something that's shutting all that down. It is like kind of being, hitting a wall. So sometimes it's the intensity of just the how quickly it comes on that impacts that. But I think the overall side effects are very manageable. And I think that if nothing else, again, being prepared for them. And again, I think our providers do, the job they're meant to do. They want to keep you on their treatment. So they don't want to talk too much about all the bad things that can happen because they want you to be motivated to continue on treatment. But I think it is important to leave space for patients to be able to say, hey, I'm having this side effect and I don't know if it's related to treatment. Can you help me? And the thing that breaks my heart is when a patient tells me that they've gone off treatment, they've taken themselves off treatment because nobody would validate that they were actually having these effects that impacted their
Mm,
quality of life. So again,
yeah,
I just
yeah.
want that, like, always want the patient to feel comfortable saying, I don't feel good on this medicine, and how can we address it? And then if that's not a conversation your provider's willing to have with you, then you probably need to think about seeing a different provider or going to someone else for an opinion to help you address the side effects in particular. Does that help? Is that what we were?
Yes, yes, absolutely. Thank you so much. And the persistent side effects, someone had mentioned they shared their experience with persistent side effects. Um, do they typically, how do these side effects manifest? I guess do they continue after treatment? Are they only on treatment? What should patients expect?
I think it really depends on the person and the treatment itself. And that's where I think having, some way to record your symptoms, whether it's a journal or an app, or you just jot down, your feelings for that day and just see if there's a pattern. Persistent to me is like over time, right? Like over, are we talking like over 2 to 3 weeks, and someone's pain is increasing? I always get more concerned when the pain or the side effect is getting worse and not getting better, we're not managing it. Sometimes, I'll say like, let's check in a week, let's keep a track, are you having pain at a particular time? Are you having difficulty? If it's hot flashes, like, are we having hot flashes every day? Is there a trigger? Are you a caffeine
Mm-hmm,
drinker? Are you an alcohol
mm-hmm,
drinker? Like, what can we do to kind of, with our own symptom management, kind of like address some of that? And if it's not getting better, then yeah, I think there is a referral to, a gynecologist to talk about, going on a SSRI block, something like an antidepressant that might help with some of those hot flash symptoms. And again, it may not be forever. It may be for 6 weeks to kind of get you through that adjustment period. And then it's, you know, tapering off, and then maybe you don't need to be on that anymore. But I think for provider from the provider perspective, I think it's helpful for us to have as much data and as much information as we can get from you. So if you call me and say, I just started having pain yesterday, I'm going to say, okay, well, let's talk about where that started. Was there some reason? Like, did you have an injury? Is this from, something you've ever had before? And then if not, no, this is sounding suspicious or concerning over time, maybe a week or two. Does anti-inflammatories help it? Can you, notice like if you put ice on it or you elevate it or you don't walk for, is it better? It's the same questions you would go get from a from a physical, like a sports medicine consult, but you want to kind of just make sure that we're ruling out like an acute injury versus something that has happened, because of treatment. So I think just watching and monitoring and journaling a little bit about like what the impacts are is helpful. And then, going ahead and getting the patient in for an assessment. We talked about the beginning, and I didn't really say it on in the presentation, but patients a lot of times are going 6 months or even a year between visits if they're just in the maintenance phase. So if someone's 2 or 3 years out from treatment, they may not be seeing their provider on a regular basis. So it is okay to make appointments or to reach out in that interim and say, I'm having this new symptom and it's concerning to me. And again, they may bring you in for an assessment, or they may just say, hey, let's talk about your concerns, or let's make a referral, or have you come in and we'll discuss it more.
okay, yeah, that makes
Yeah.
sense. Um, So we have so many questions and they're so good. I wish we had more time. I wonder if maybe we could send the questions to you and
Yeah,
somehow have them answered and send them out to
sure,
our
sure.
participants. I'd love to be able to do that. Thank you so much.
Yeah, I'm happy to do that.
Yeah. Okay, that would be
I do see the ones about like itching and hives and things
yeah.
like that. So, certainly depending on, it's hard to know with depending on the treatment, like if hives and itching can be caused by so many things, but certainly we do see them when someone's immune system is impacted. So that would be something to bring up to your treatment team just to make sure they're aware, and there may be a good reason for it. Topical steroids sometimes are the thing that most of the time they'll say, as long as you're not in treatment like getting radiation actively, they'll say try that to just kind of settle things down. And then it may be that we need to look at like what is the underlying cause. Like hives tend to be allergic. So it's like, what's causing you to have that reaction? Um, and then I see the questions about radiation and creams and, kind of addressing skin issues. Again, I think the main thing I would say with that is to report your concerns to your team so they can give you the best suggestion. It depends a little bit where you are post treatment. Like, are you in the, you know, still in treatment? Are you in the 6 weeks out phase? Are you in the, 6 weeks plus? Are you more than a year out? Because that would change our guidance in terms of what we would recommend for skin. But absolutely, I want you to all hear that these are all normal, expected side effects that we see and that you're not going to be laughed away. You should absolutely bring these to your provider team and make sure that you're heard so that you can get an answer and get your concerns addressed.
Thank you so much.
Yeah.
Um, so before we wrap up, what are the key takeaway or message that our audience can walk away with?
I just want to empower you to have these conversations. I want you to know that the quality of life that you're having concerns about, whether it's, physical pain or, feelings about yourself, concerns about mental health, whatever the concerns are that you're dealing with as a cancer survivor are important. And we want to empower you to communicate those. So make sure that this is an ongoing conversation. And if it's not natural for you to bring things up, you feel like you're complaining or you're wasting their time or you're concerned about being a burden, let that go. Find somebody on the team that you can trust to have that conversation with. It might be the social worker, it might be the navigator, it might be hopefully it is somebody like your medical doctor or your medical provider. But find somebody that you can really connect with and voice your concerns to. Because I think that, having that relationship, this is not temporary. This is not like you're going to somebody for one procedure and you're done. This is life, right? This is your continuum, your life continuum. So this is your team going forward. So it's important to have that relationship. And I do see the question about pain, and pain is a good one. I can end on this one, but dealing with chronic pain is a great example. Pain will come and go as a cancer patient because you're going to have it from treatment acutely, and then you might have chronic pain over time. And managing chronic pain is certainly something that people with, small cancers that are treated and also metastatic cancers deal with. But that is an example of how we can, communicate with our team and say, I've noticed this about how I'm feeling, and I'd like to notice that it's different than, how I felt before. And can we talk about how I'm going to manage this going forward? And just come from that place of empowerment rather than hoping that somebody asks you about it so that you can tell them how bad it feels. Like, we don't want you to
Yeah.
be the one
Mm,
waiting to be asked, because frankly, in our system, things are so crazy busy and there's so much priority for specific conversations and checklists and things like that, that unfortunately a lot of times those conversations do get missed unless the patient brings them up. So that's my long-winded way of saying, reach out to the people that you can trust and be a partner in your care, because no one is going to know how you feel unless you tell them. And it is your job. It's our job to manage your symptoms. It is your job to just let us know how you're feeling, for real. Being real.
yeah. Yeah. So true. Yes. You're not mind readers, right? You're not.
Sadly,
Yeah.
I wouldn't
Yeah.
be I wouldn't be doing
Yeah.
this job if I was, but
Right. Right. So that's so important to
yeah,
communicate,
yeah,
whatever it is, and not to be afraid of saying how you feel.
right.
So, yeah. Thank you so much, Emily. We really appreciate your presentation and answers to our questions. I also want to thank everyone who joined us. We will have a recording of the program available on our website in about 1 to 2 weeks. Also, please make sure to check Share's website for upcoming educational programs, podcast episodes, and support groups. And don't forget to follow us on social media as well. Please take a moment to complete the survey at the end of the webinar. The survey will pop up in the browser when the webinar ends, and the link will also be in a follow-up email. All surveys are anonymous. This concludes the webinar. Thank you again so much, Emily, and I hope that everyone has a great day and rest of the week.
Thanks, Kate. Y'all have a great week and feel free to reach out if I can be helpful. And
Of
I'm happy to answer these questions, like you said, in a follow-up if
Okay,
that would be helpful.
great. Thank you so much.
Yeah.